So I'm going to speak to you today about contrast-enhanced ultrasound, and we are a situation at Jefferson where we've been looking at ultrasound for the prostate for the last 30 years, and it's been a large prostate center. Just to review, the normal blood flow to the prostate is a radial pattern. It's sort of symmetrically distributed. You can see there's blood flow on the neurovascular bundles bilaterally. BPH is a big factor in looking at these ultrasounds because people have BPH, which increases blood flow. They also have asymmetric BPH, which causes asymmetry in the blood flow. So some things that we have to pay attention to. But this is the examples of where color Doppler is helping. If you look at this prostate here, the image on your left is color Doppler, the image on your right is power Doppler. So you see here that there's an area of increased blood flow with color and power Doppler, and that really marked the site of the cancer. But bottom line, at Jefferson, I can go through these numbers, but standard ultrasound with our 6 to 9 megahertz probes was basically similar to random chance. Color Doppler did not do much in terms of improving the detection. We have asked the exact imaging people if we could do a study with their machine. They've been, I think, somewhat hesitant to loan us a machine to do the comparison. But we've been doing our research with contrast-enhanced agents. The advantage of contrast-enhanced agents is, once again, you can see smaller vessels. So as it was stated in the last lecture, regular ultrasound has about a millimeter size resolution, which is about the best you can get. But with contrast-enhanced imaging, because the contrast goes into smaller vessels, when a contrast bubble ruptures in smaller vessels, you can actually make out those smaller vessels, even if they're below the resolution of your ultrasound systems. So microvessels in cancer, which are in the range of 50 microns in size, can actually be visualized with contrast-enhanced color Doppler or with contrast-enhanced grayscale. And here's an example. So this patient, this is a prostate which was completely homogeneous on the standard imaging, but with contrast enhancement, you can see this right area here is lighting up, and you can see contrast-enhanced color and power Doppler, as well as contrast-enhanced grayscale harmonic imaging showing you the site of a cancer. Flash replenishment was a technique. This is a rat testicle, I believe. And the bottom line is you can see all the small vessels here with contrast-enhanced imaging. What happens is there's a high-power flash which destroys the bubbles, and then a lower power pulse demonstrates reperfusion. You can actually image the course of the vasculature. And so that's very interesting. This composite image we get with flash replenishment imaging lets us evaluate not only how much vasculature there is, but it lets us look at the anatomy of the vascular tree and see the branching pattern. And so here's some examples with prostate. If you look closely, you can see here, this is contrast-enhanced imaging. You can see the contrast coming into the prostate. So this is the whole prostate here. The peripheral zone is out here. You could not make out the cancer, but you can clearly see here that there's vessels that are coming into that cancer. And in the flash replenishment imaging, you can see that there's a sort of a haphazard pattern of contrast in the area of the cancer. Here's another case. And once again, the flash replenishment imaging is showing you the site of a cancer. And we've had this with several cases. So I just want to show you some examples. And so here again, this is an example actually which is visible on grayscale because it's sort of hypoechoic here. But with contrast imaging, you can see there's it's very hard to see without the contrast, but with the contrast, you can really see some increased flow coming to this site of the cancer. And this is the flash replenishment in the bottom left side. That's the bottom, and this is the bottom right image here, where you can actually see on harmonic imaging there's a haphazard pattern of these vessels. Yet another example, and once again, just to move through this is the flash replenishment imaging here. And although on color Doppler and power Doppler there's some increased flow, it's hard to make that out. With the flash replenishment, you can see vessels in some kind of distorted pattern, which is not following the typical radial pattern from the neurovascular bundle into the prostate. So we've published some data where we show that flash replenishment imaging directed biopsies, MFI is just one vendor's version of flash replenishment, and we show that the systematic cores compared to the directed cores with flash replenishment imaging, that we do a much better job with flash replenishment imaging in terms of selectively detecting higher grade prostate cancers. We recently just published the Homeout prostatectomy study where we looked at 58 patients who underwent contrast-enhanced ultrasound as well as radical prostatectomy. We used a 5-point scale, and the bottom line was when we used contrast-enhanced ultrasound, we really improved the detection. Now, this looked at a lot of patients in our earlier studies, so there was not a lot of experience at this point in time. But nonetheless, 49 of 52 patients who had a significant prostate cancer and Homeout prostatectomy had corresponding findings on the contrast-enhanced ultrasound when we went to look at them. And this is a study that was published back in Journal of Urology, showing the use of contrast-enhanced ultrasound for detection of tumors. And when we went to what we thought were the clinically significant tumors, which is high volume tumors defined as greater than 50% core involvement and greater than or equal to Gleason 7. So the area under the curve there was basically, when we used grayscale with flash replenishment imaging, we got an area under the curve of 0.9. So that was about as good as you can get with most of our targeted MRI studies as well. One thing I really want to talk to you about today, though, is most of this stuff I talked to you about now, we could have talked to you about last year. The new thing that we're looking at is subharmonic imaging. And we just concluded an NIH study. It was a pilot study, an R21 looking at subharmonic imaging. And what we found was that although conventional harmonic imaging is limited by the blood to contrast ratio, subharmonic imaging is where you insonate, let's say, at 5 megahertz and you're receiving at 2.5 megahertz. And so there's almost no signal coming back into subharmonics from regular tissue, and almost all the signal is coming back from contrast agents. And so the slide on your right is a regular grayscale. The slide on your left here, this is all the color is showing you the subharmonic imaging. So there's less interference from regular signal. And this is just a real-time example. So here we got a real-time sweep through the prostate. This is a normal prostate. You see a very symmetric, well, actually he's got BPH. So you see all the BPH flow here, and you see a relatively symmetric flow pattern in the outer gland. As opposed to this case here, where we're looking at contrast-enhanced imaging with subharmonics, and this slide down here is showing you that this is the inner gland. You can see that the inner gland is lighting up a little bit with the BPH, but if you compare the right side of the peripheral zone to the left side, the subharmonic imaging really lights up very nicely. And this area, when you go back and look retrospectively, all this is contrast-enhanced power Doppler and some contrast-enhanced color Doppler. It's hard to make out that there's more flow in here, but clearly on the subharmonic imaging, you're seeing the area that turns out to be cancer has more flow in it. So here is a real-time sweep in another patient with subharmonic imaging. And if you look on the image on your left, this is the grayscale image. You really can't make out too much going on. But on the right, the entire left side of this gland has increased flow. And there was tumor, it was high-grade tumor, going all up and down the left side of this prostate. And we could really detect that very nicely with subharmonic imaging. Yet another example. Here's a patient with this at the base of the prostate. The grayscale imaging basically looks relatively homogeneous, but when you use the subharmonic imaging, you can see there's increased flow here. Now the flow pattern here, you can sort of see this is a microflow type image. There are vessels that are sort of radially going in toward the midline, but here this is a blotch of contrast enhancement. And I will admit that there is a learning curve in looking at these as well. And there is a subjective nature to this, but I think it's relatively easy for you to see, hopefully, that there's a major difference between this left side of the prostate with contrast enhancement. So we have a pilot study now with 55 patients. Prostate cancer was identified in 24 of those 55 patients. It turns out that it's getting very difficult for us to get patients for our study. And part of the reason for that is because the MRI people are getting better. And so the only patients that are getting sent to us now are the patients with negative MRIs. So in our study of 55 patients, 31 of them have prior negative MRI. And we went ahead and we did the contrast-enhanced imaging, and basically we found 9 of those cases. We found significant cancer in 9 of those cases. And the subharmonic imaging is helpful for that. Using a univariate logistic regression to try to figure out which parameters were useful. It turns out that grayscale was really not useful at all. And although color and power Doppler did have a significant predictive value for the presence of cancer, the contrast-enhanced imaging, and especially the contrast-enhanced imaging with subharmonic imaging and subharmonic flash replenishment, had the best p-values in terms of detecting cancer. So sort of in summary, multivariate conditional regression shows that when dependent variable is prostate cancer within a sextant, and looking at all the other imaging parameters as independent variables, subharmonic imaging was a significant predictor. And it was an independent predictor beyond the baseline grayscale and Doppler imaging. So in conclusion, we sort of looked at all the different ultrasound modalities that we've looked at. We've looked at conventional grayscale and all the different ways of looking at flow, and this slide summarizes them. Bottom line is color and power Doppler were the initial ways to look at flow. There was a lot of artifact because of splotching from color Doppler into adjacent areas. Contrast enhanced increases your sensitivity, but still subject to that artifact where there's sort of spillover of color flow into the adjacent areas. Harmonic imaging gets rid of that artifact. The grayscale imaging doesn't have that spillover. It also has better resolution and relatively good temporal resolution as compared to color Doppler. So it seems to have a major step forward. And the flash replenishment imaging is a major step forward from that because it allows us to see the vascular patterns in addition to just the amount of vascular enhancement. And finally, subharmonic imaging, I think, is giving us an even better view because it's increasing the signal to background ratio. So it's giving us a better view of looking at contrast-enhanced imaging of the prostate. So I think that this is a way to go in the future. Selective enhancement of neovessels with subharmonic flash replenishment is, I think, a way we're gonna head for looking at prostate cancer detection. We actually just submitted another grant to the NIH. We've been trying to get them to fund a proposal comparing head-on MR to this contrast-enhanced prostate technique. We have not been successful in getting funding for that. So now we're gonna try to just look at the patients who are negative on MRI. And it seems that we have a 20 to 25% clinically significant cancer detection rate among our MRI negative patients. And so we're gonna see if we can do one of these contrast-enhanced studies in that population. Hopefully, we will select future patients for biopsy and limit the number of biopsies with this technique. Thank you for your attention.